rather than the whole group of us, everybody doing 10 to 20 of them, and everybody doing 10 to 20 shoulders, and everybody do. We also get better at what we do by being specialists and honing in on that, and the volume of doing that repetitively as well. So that's what I deal with a lot. And I brought some things to play with here to talk about with a hip and knee replacement, but we can talk about anything, and we can talk about anything as it goes along and pertains that comes up that you feel would be worthwhile talking about, then we can do that. I had a patient in the hospital that I took this from today. We have to return it so they can get up and walk later. Yeah. We can't let them just stay there all. They were kind enough to help us out. I'm not even sure how that gets back on there, but. All right, so what are we dealing with? Mostly what leads to hip and knee replacements is pain in our joints, right? And the usual cause of it is osteoarthritis, wear and tear, degenerative arthritis, meaning that the joint just wears down over time. So things that precipitate or can lead to more wear and tear or injuries to that joint. So I'll end up doing a lot more knee replacements in a year than I will hip replacements, because we injure our knees much more often than we do our hips, and that leads to injuries of the knee joint that eventually lead to osteoarthritis or degenerative arthritis wearing out of that joint. So a lot of our sports medicine doctors, excuse me, who take care of sports knee injuries when they first start out, evolve sometimes into joint replacement docs, because those same patients that they took care of 20 years before with knee injuries now come back to them and say, well, yeah, my knee's hurting again, and now it's an arthritic situation. So you can see how that over time gradually happens or whatever. But that's generally what happens with wear and tear of the joints. And it's like if I walked across this carpet, eventually I'm going to wear this carpet out, right? Just like our joints happen to wear out over time. There are other arthritic situations which are more rare, like rheumatoid arthritis or infectious arthritis or lupus arthritis, and they might happen with something spilling on this carpet that rapidly dissolves the carpet, down to that would almost be like how it happens. I have a little bit of a cough, so I don't want to cough into the excuse me. That's an important difference of how that happens. So how do we treat the pain? We treat it with Tylenol or an anti-inflammatory like Advil, ibuprofen, those things. We treat it with shots like cortisone, shots like gel shots. Some of us have probably had some of those, right? Yes. All right. So what works best for you is something that we will do and help you with. You know what? Let me use the microphone, just because I think I'm gonna just getting over something, and I'm probably gonna cough a little bit, and I don't want to be annoying. This way I can put the microphone down if I cough. Whereas with this on me, is that hooked on me?
Yes. Okay.
Whoop, sorry. I'll put this right here.
Okay, you're gonna grab the other mic?
Yes. Excuse me. All right. So, and when I talk a lot, which I never do, I try to, I try to, I tend to get a little bit of a cough with it too. But anyways, so what do we do when we have these pains? We want to treat it. We want to do what we can to make it feel better, right? So we're going to take some medication. We're going to do those things. We're going to take some shots like cortisone, a good anti-inflammatory, something that really helps the joint. So that's going to be something we're going to do. And then there's these gel shots. How many people have had some of those, the Visco, like the Synvisc and Hyalga? And you know what? They help, but there's no fountain of youth out there. There's nothing I have that I give you in that knee joint. Let's say the knee. You're all about 50 to 55 or whatever. So let's say there's nothing I have that joint is going to go down to the 40s again for you, right? I don't have that pill or shot or whatever. Nor do I have the shot or pill or whatever, that if I give it to you, your knee stays at 50, 55. You get to be 56, it's getting to be 56 with you. All the treatments are trying to help you feel better, to enjoy your time, until maybe you come to the point that you say, hey, that's it, I'm ready, let's do a knee or hip replacement, I'm tired of this. And yes?
Why does the drug, I mean, it's not a drug, it's a supplement, turmeric. How can that help?
Well, okay. She asked, and I'll try and repeat it because not everybody can hear she asked, why does turmeric help her? And there are natural anti-inflammatory herbs, whatever way you want to think of it. And again, the big thing here is we're trying to reduce the inflammation. So, osteoarthritis is osteobone itis inflammation of the bone. So you're taking turmeric, which acts in a lot of people as a natural anti-inflammatory. And so does Advil, Aleve, ibuprofen. They work by being an anti-inflammatory. Okay? Tylenol is not an anti-inflammatory, but it can help with pain. It's a good pain reliever, also helps with fevers, right? But it doesn't have that anti-inflammatory effect. And there are some other herbs or natural remedies too that can help with inflammation a lot. And I think the gel shots that some of you raised your hand and said work by being an anti-inflammatory. So all of these are working on reducing the inflammation in the joint where your body's attacking the joint, and because it's trying to help it, and the way it does it is bringing in these anti-inflammatory markers and everything. My favorite natural, like you mentioned, turmeric. Does anybody take any others? Supplements or natural things that they like or whatever to take for their joints? What do you take?
I take pure sulfur. Pure sulfur.
Pure sulfur. Yeah, so she takes pure sulfur and that helps her with that. What I like to do is, and I have some inflammation in my joints, I like to get these golden raisins, right? Golden raisins. And I put them in a little pan and I pour a little gin in there. And I let it sit for about 5 days. And then I take about 5 or 6, 7, 10 of those raisins and I feel better all over. So just keep that in mind. That's just one of the ways I think of reducing the inflammation. So there's lots of ways. whether by medical ways or by natural ways, to try and reduce the inflammation and try and make your joints feel better. But there may come, and the steroids, the cortisone shots, which is a steroid, that's a great anti-inflammatory. Some of it, long-term, can have its side effects, but just having a shot in your knee every so often is not a problem at all. But if you were to have to take the steroids by mouth for a long time, that might affect you and everything, so we don't like to do that. But if you have an acute case of rheumatoid arthritis, one of the big helpers of that, in the past at least, was being on high-dose steroids to reduce the inflammation of the acute episode of rheumatoid arthritis. So if we try all these different things, and we may come at some point to the point that we say, none of this is helping, or I'm not doing the things I want to do, and this is preventing my knee or my hip or my shoulder or whatever it is, and you may come to the decision to have surgery, and that may be a hip or a knee replacement. And what they're going to do is put a new surface on that bone, so that worn out surface that you have, that wore down, and you have bone on bone now you put a new surface on that bone that articulates smoothly and allows a freer range of motion again for you. But it's surgery, so you have to take that into account, the issues with surgery. Now, certainly 30 years ago, thinking about surgery for a hip replacement or a knee replacement is certainly different than it is now. 30 years ago, we'd bring you in ahead of time. We'd check you out. We'd do our testing in the hospital. We'd do our surgery. We'd let you lay there in bed and feed you grapes and not do anything for a day or two, and then would get moving. Now, I do my hip and knee replacements. I expect you to leave that same day. I want you up, walking, going. See you later. You don't have to stay in the hospital for it. Now, that's not for everybody, but that's the majority now. Certainly, some people need to stay over because of their situation or whatever, and the hospital's available and there for that. But that's how things have changed. Instead of being in a week or more in preparation and everything being normal, now you're out that same day I do the surgery in the morning, you leave in the afternoon. So you can see how, just as orthopedics and medicine is evolving, you can see how joint replacement is evolving into that as well. Yes?
What is the role of robotics in surgery or knee?
His question was, what is the role of robotics in hip and knee surgery? So probably that's one of the better, I think, advances that we've made over the past 10, 15 years or whatever, is with robotics. So if you come in and I see you and you need a knee replacement, and we agree that's the best approach to go at this point, we'll get a special scan of your knee. And that scan will come back with a plan specific and individualized for that knee. It'll sort of print it out on the computer and be part of the computer settings and show how it fits in the position and where it would be best and all that type of stuff based on your anatomy and based on the scan of your joint. And then at the time of surgery, when I go to do that surgery, I may tweak it a little bit. But once I lock that in, I use a robotic part, sort of like a saw. I use a saw, but it's attached to the robot, if you can think of it like that. And that robot is hooked into the computer that's in the room that has that scan and that plan for you on it. So they are connected, and when I go to do that surgery, it only allows me to cut the bone exactly for that plan. I can't move it off plane. I can't make an error and go too deep, and so it makes me better. I've been doing it for 38 years or so. It makes me better, so it makes it better for you. So it makes sure that I don't go off plane. Now, I can stop it, rearrange it if I don't like the way it's going or whatever, and reprogram it, but I haven't had to do that. It sits in there exactly as the plan is. So there's less bone cutting errors. There's less soft tissue irritation from the saw blade going out into the tissues, because we sort of put parameters around the cut so that when we go out of those parameters, the saw blade turns off. And so it protects you that way. So it's become a big part of orthopedics as well as surgery in general. But the surgery that they, excuse me, the robot they use for general surgery is different. They do that surgery. In other words, you come in the room, the robot in general surgery is over top you. They bring it in with multiple arms, and they have an assistant in there that helps make the surgeon make the cut. But the surgeon's over here moving everything like you're playing a video game and doing the surgery in real time here while that's doing the surgery. Whereas in orthopedics, I'm still working the robot and doing the surgery. I'm sitting there doing it, but the robot is programmed and prevents me from doing certain things to make sure we do it exactly as we plan. So it's so the robot in general surgery is different than the robot in orthopedics, just so you know. So it's a little interesting fact there with that. And they call the robot in general surgery the Da Vinci, and you may have heard that, right? And the one I use, which is the robot of choice and the king of robots in orthopedics, is called the Mako robot. So that's the difference in those two. Yes?
Do you always use the robot, or do you do surgery without using the robot?
She asked if I always use the robot in my surgery. I always use the robot with my knee replacements because it's so good, it's so refined, it does a great job, and I always use it. With the hip, I don't, because it still needs some soft tissue improvements over time. But it's getting there, and it will be eventually that we use it all the time in all these surgeries. Yeah. Yes?
I'm told there's no perfected ankle replacement.
Well, I think they're pretty good now with ankle replacements. They don't do a lot of them, but they're much better than they were before, for sure. So I think they're improved, and we do more and more of them. In the old days, if you had a bad ankle or a problem with your ankle, what we tended to do was fuse it. Okay, make it solid, so there was no joint there. So you get pain from that joint rubbing and moving and getting irritated and painful. So what we would do would be to fuse it solid, then you wouldn't have any pain, because you don't have any pain in your arm here where it's solid, right? But where there's a joint, you could have pain, and a joint is anywhere two bones come together, right? So you can have a joint in your fingers, your neck, anywhere. Anywhere where two bones come together, it forms a joint. So that ankle joint, we would fuse and make solid. Now that would make your gait a little stiffer, right? But it would take the pain away. So for people with a lot of pain, it was helpful. But now we've evolved into the ankle replacement as well. And we're much better at that, and it's a good operation. I really believe so. That it works quite well. Yes?
I'm going to change the subject. I hope it's okay.
You change whatever. I'm here to talk about whatever.
Okay, so, I grew up on a chicken farm and always would carry a big bucket of chicken feed, okay? So I felt like I was strong. I got a job at Nordstrom when that came to town, and I had to, I'm short, and I had to reach up, put clothes on a rack up above my head. Well, that, my rotator cuff would fly out, and that was like, 10, 15 years ago, and it still does. Why can't that be fixed?
She wants to know, she has trouble with her shoulder, she has some rotator cuff issues, and she wants to know why it can't be fixed. I don't know, she didn't come to see me. I'm not that I see shoulders or something, but I'm sure someone could fix it.
Well, I did have an operation, but it still pops out if I'm not careful. And I reach too quickly or whatever, and so I've just learned to relax myself. And then relax, hoping that the pain will start to go away, and then I can just pop it back in. But
Right. So she has some instability with her shoulder as well, she's describing. And I think that you may end up with a reverse shoulder replacement. That'll correct that.
well, I'm thinking, will that stop it?
Yes.
Do you think at 85 it's worth it?
Why not? What if you live to be 95 or 105? My goodness, why not? That's up to you. And that's what I tell everybody. People will say to me, well, I say, you'll know when you're ready for a hip or knee replacement. You'll know. You'll make that decision. And if at 85 you feel you're old and too old to have a shoulder replacement, then go ahead. Don't do it. But if you feel 85, you're young and you want to still do things and this annoys you, go get it done.
It still pops out sometimes in the middle of the night when I'm rolling around, but I wear a T-shirt.
Are you happy with that?
No,
Well, then I think I'd probably say, go see Dr. Hurley. He'll fix you up. He's our shoulder guy. Shoulder expert. But that's what I tell everybody. You'll know when that time is. And the funny thing is, and not funny, or a different thing, I should say, difference, is I see a lot of younger people, maybe you guys are in your 50s, I said. I see some people in their 40s. They come in for thinking, and you know what they say? I say, well, this is this, and this is what we could do. Now, let's just fix it. And more of the younger people are of that mindset. I don't want to go through shots and therapy and waiting and this. And we all have different mindsets, and we all may say, at our young age of 50, we may all say, well, we'll wait a little bit, I'll see how it goes, I'm not ready for a hip or knee replacement. But that's also an evolving trend in medicine. People are getting less patient with a lot of things, and one of the things is putting up with a bad hip or a knee. And they're of the mindset, I'd rather start now, get it fixed, because they last probably forever. All right? So they're not thinking 10 years from now I'm going to have another surgery, or 20 years from now I'm going to have another surgery or whatever with it. Yes?
How does exercise fit into all this for prevention and so forth? You haven't mentioned, being physically active. Get the pain.
Well, therapy, she asked, where does exercise play a part of your arthritic joints? And certainly building the muscles around your joints can help them. and strengthen and make them more stable and maybe take the pressure off them and less pain with that. And physical therapy plays a big part of that with us and helping with that. But you also got to remember that we mentioned this is a wear and tear of the joint, right? Degenerative osteoarthritis, we call it. It's wearing out. So sometimes jogging's a great exercise, but if you have a bad knee, well, that's not going to do you any good. So you have to be sensible about how that exercise, how that therapy benefits you. And there's only so much it can, but there's nothing wrong with trying to strengthen that joint to help stabilize it and make it feel better. But also, the more we do on it, the more we're grinding it away. So there's a happy, medium there with the exercise of where we go, what we do, and everything else with it. Yes?
What makes a knee lock?
Probably the biggest thing that makes a knee lock is pain. People will say to me, oh, my knee lock. Probably they had a pain and they couldn't, and they didn't want to move it any more than that. There's other things like a torn meniscus that can get caught in there. But as we get older, the meniscus is more degenerative. That's in a younger person that were in their 20s and 30s. It's going to lock up with a torn meniscus. You may get a loose body that floats around in your knee and gets locked into between the bones and can catch in you there and prevent you from moving the joint until that loose body moves away, and then you have a freer movement with that knee. But I would say if most people came into me and said, oh, my knee locked on me, 7 or 6 out of 10 are going to be it's just pain, and it got in the way, and it locks on you until that pain eases up. I know I've had that a couple times. I couldn't even walk on my ankle until I, just loosened it up a little. Yes?
I know I had x-rays done and there are loose particles.
Okay.
Is there anything you can do about that?
We can go in and remove loose bodies, as we would call them, floating in if it's your knee. Yep. We could go, especially if we felt one of them is moving around and catching you and locking you in a bad position, and until it frees up in that or whatever, it's floating around. Yeah, and we do that, for sure. Yes?
You talked about the replacements lasting forever, but I know several people that have had hip replacements that have had to have them redone because they've worn out.
Well, they may have at that point, but now, and I've done some 30 years ago or more. They're still going good, but there's some that come into me at this point, and I'm revising some of them and redoing some of them. But now, the materials, I'm saying, are so good, right? I'm not comparing them to where they were. We've advanced those to the point that most people that have a joint replacement now, they don't wear them out.
I haven't heard of knees, but I've heard of hips.
Okay. She said she hasn't heard of knees wearing out, but she's heard of hips. They both can wear out. But in general, the advances that we've made with the materials that we use are so good that they last over 30 years. And for most people, that's long enough. They don't need it longer than that with it. Yes?
Can you kneel on a replaced knee?
She said, can you kneel on a replaced knee? It can be hard, but yes, you can. And everyone's different. You may get a replaced knee and feel comfortable on your knee, and the next person may not. In general, I don't think they're comfortable. You'd have to pad it up. If you want to go outside and do some gardening, you take a good knee pad with you and something that you can kneel on or whatever. They're not made to just kneel on the hard surfaces. So, and your knee will tell you. It'll tell you, it'll say, no, I don't like you kneel like this. You better put a big cushion here or something else, or don't do it. And it'll let you know. And other people can, I kneel and I don't have any trouble. Everyone's a little bit different. But in general, I'd say they're not easy to kneel on. Yes?
16 years ago, I had both knees replaced. And a year ago, you replaced the part in my knee that I broke when I was kneeling. And since then, I do not kneel unless it's absolutely urgent. And I do a lot of gardening. And I heard what you just said. If I use a thick piece of foam, I could kneel sometimes, or would you recommend don't kneel because you're going to pay?
I think if you pad it up well, he asked if he could kneel, if he really cushions it and pads it up well. And I think you can get away with it. I just wouldn't do a lot of it. But occasionally, if you want any, he had an issue where he had his knee, part of it broke off from him kneeling on it, and he had his surgery done elsewhere, and he came to me because maybe he was in this community, and I helped him. And I redid it for him and fixed it. But so I've been cautious for him to go back to being a wild cowboy on his knees and everything.
It's been good.
Good, good. So what else do we want to know about? Robot, go ahead, do you have a question?
Can you explain the difference between spurs and arthritis?
So the question is there a difference between spurs and arthritis? So, arthritis, as I mentioned, arthur is joint, I may have said osteo, which is bone, itis, which is inflammation of the bone. Arthritis is inflammation, itis of the joint, arthro. So, spurs develop from the arthritis. That is your body's mechanism of trying to fix the arthritis. And it builds these calcium deposits and other things that lead to spurs. The spurs are not the cause of the arthritis. The arthritis is the cause of the spurs. So if you come in and you say, oh, I got this spur, take this off, I'll feel better. Not if it's from arthritis. Your arthritis is still there, you're still going to have the problem. The spur is not the problem. People like to think maybe the spur's the problem. It isn't. It's a reaction to the ongoing inflammation that we talk about and of that joint and your body's mechanism of trying to heal or trying to deal with that inflammation in the joint. Did that answer the question? Yes.
It's my understanding that with a hip replacement, total hip replacement, that it's cut out and glued. A new replacement is glued in there. But I know someone who had a total hip replacement, and they said it wasn't glued in, it was fit in. How does that work if it's not glued? How does it stay there?
So she said she was under the impression that hip joints are glued, but she had a friend or someone she knew that didn't have a hip joint that was glued, it was press fit. And I would say the answer is, and I'll show you how that works, we rarely cement a hip. That would be an abnormality for us to do. We always press fit a hip, and we've done that for years. Since maybe when my first few years, I would cement some parts of a hip in 30 years ago or more, but we haven't done that for 30 years plus. So almost all hip replacements are press fit, put in tight without cement. Now, if you have a lot of osteopenia or osteoporosis and your bone quality is not good, we may use cement to bond it in that situation to give you some support. We may, but it's just the opposite of what you're thinking. We rarely do that, but on occasion we will. So how do we do a hip that is press fit? I need glasses. I need my reading glasses. There's a hole here, I gotta get it in. There we go. Get in there. All right. So here is a hip replacement. So with this, you can see this is your pelvic bone up top, and this is your femur bone below. And remember, a joint is where two bones come together. So this femur bone fits into the pelvic bone. All right? So that joint, that ball and socket joint goes bad and wears out. So we have to fix both sides of that ball and socket. We can't just fix one side and leave the other side worn down, because the part that we put in against it will still irritate you because that's worn out, right? So we have to put a new surface on both sides of the joint, all right? I'm going to put the mic down just a second. I'll try and scream so you can hear me. So what we do is we cut the bone with the ball that was sticking here off. All right, we cut that ball and this acrylic or clear is your bone, your femur bone. Okay, it's sitting in here like this, right? And this is your joint. And your hip pain usually is right here in your groin. Not up here, not back here. That's usually your back. You're having hip pain and you think it's up here and behind, that's usually your back giving you that pain. But anyways, here's your hip in the groin. So we take that out and we drive this bone, this metal, titanium, down into the bone. And it's tight. And we mill it out, different sizes. And then we stuff it in there. All right? We do the same thing on this side. We mill out that round socket and stuff this metal cup in there. Tight. All right? And then inside this metal cup, we put a piece of plastic or polyethylene plastic. This fits, and you can see how it's modular. So if it ever did wear out, we could take this out and change it and just put this in. But that fits in there. All right? Just do it again. But then this fits into there, and that's your joint. And you have a new surface, right? That worn out surface would make a nice articulating surface for you again. And they're both press fit in there. So that helps you at least understand how do we get that in there tight. We'll mill it out to, say, a size, we'll use numbers 1 through 5. That's not what we do, but 1 through 5. And so we mill it to a 4, and then the real one that we pull to put in, that size 4 that we have rasped or broached to that size, is just about 1 millimeter thicker. So to go in there, it's tight and it scratches as it goes in against the bone to hold it. It's a scratch type fit. And then the body loves titanium and it grows to the titanium. and grabs around it and locks into the metal. So that metal will stay for 100 years. But that articulation, that plastic, is what would wear over 30 years or so. Yes?
Is there any nickel in titanium?
No, no nickel in titanium. There's nickel in cobalt chrome or stainless steel, which we use in the knee. In the hip, I have a metal ball, but I don't use a metal ball anymore. This is an old model. This shiny metal top that goes in against the plastic, we use ceramic now. So it's a ceramic ball. So in the hip, there's no nickel. But in the knee, there is nickel. It's stainless steel that moves against the plastic. This is an old nickel head, stainless steel head. We don't use it anymore in the hip, but the reason we do use a stainless steel in the knee is, and we used to use it in the hip, is you want a hard metal up against that soft plastic. Because if you put a soft titanium metal rubbing where there's movement, where there's motion, it'll just eat away at that plastic. Whereas a stainless steel is hard and won't wear and ceramic is really hard and brittle and won't wear the plastic. So that's why we've moved to a ceramic ball in the hip. And in the knee, this bottom part is titanium. It gets it fixed in the bone, right? And the plastic snaps into that titanium. There's no motion there. This is all one unit. So that titanium is not going to chew that plastic up because it's not moving against it. But this femur, the top bone, has a new surface on it, and it's moving against the plastic. It has to be hard. Otherwise, if this were titanium, it would chew that plastic away rapidly. And we want it to last 30 years or so. So there is nickel in the knee.
So what if you're allergic to nickel?
Then we'd use a special type of knee that doesn't have nickel in it, that has some ceramic coating to it. It is hard to do. It's not our usual go-to knee. Again, people that have nickel allergies, we will not use nickel in it. She asked, how would you react if you had a nickel allergy? Well, I mean, I think some of you know how you react if you have metal on you that, earrings or whatever, you get a rash, you get an irritation. It'd be rare, but you could get a rejection of the knee or whatever. But rare. Yeah. Yeah, it's a rare thing to have, and to have a rejection to it or irritation to it. Inflammation from nickel allergy. But most of those people will do a test and they'll show an irritation to nickel as like an allergist tests you or whatever. But those people also know because they can't wear earrings, they can't wear watches, they can't wear whatever because all those have a little bit of nickel in them. All right, let's see. It's about 10 of 2. Any other thoughts, questions? Did I not answer anything? I mean, I just sort of went around the horn there, talking about various things. But where's the party later? And am I invited? All right, well, yes.
About 2 months ago, I was in the kitchen, at the kitchen counter, all of a sudden my knees turned into marshmallow. I collapsed, went down, let my head go down, called 911, took me to the hospital, there all day. They couldn't find anything. And ever since then, I'm listening to you, is there something that's happening, like I say, my replacements are 16 years plus old, that I am not aware of or that I can prevent? And it never happened before, but I could not stay and wear anything. I mean, it just marshmallow.
Yeah, he just said his knees gave out on him the other day,
No, this is a couple months ago.
a couple months ago, whenever that was, and really had no inkling or reason for it. And to be honest with you, I can't think of anything of why one day all of a sudden both knees would sort of melt to you, the point that you'd collapse or whatever. And I don't know if it was something more systemic or whatever, that you passed out from whatever. Maybe the food smell got to you and you just went, oh. Because it happened in the cafeteria. Hopefully none of the cooks are here and heard that, you know. But maybe there was something in the food or something that you reacted to or whatever. I don't know. I can't give you a good answer to that. All right, well, thank you for having me, and thank you for seeing everybody, and I hope you have a great day and a great weekend. And if you need anything from us, here's our cards up here. We're more than welcome. We're still going to be serving the community. We're still going to have great doctors, and whether it's St. Luke's or Grandview by itself, it's going to be basically the same people taking care of everything. So, but thank you for having me.
Great, thank you. Thank you. And as I said earlier, it's strawberry theme for Strawberry Festival. Stop everybody.